So, good afternoon, everyone. My name is Arshit Desai. The topic of my paper presentation is assessment of CVD related distress and psychosocial determinants. It's a prospective observational study. CVD remains the leading cause of morbidity and mortality worldwide, exerting not only physical burden but also psychosocial burden with significant distress on patients. CVD-related distress encompasses emotional strain and fear, recurrence, uncertainty, and prognosis amongst various patients. Patients with diabetes represent a particularly vulnerable group. The coexistence of this diabetes and CVD is associated with higher incidence and complications within these patients. So, based on the review of literature, we found that patients with ACS experience significant distress and death-related concerns, often related with anxiety, social support requirement, and predict long-term distress in patterns and further degrading their health conditions. Additionally, socioeconomic related, class related disparity and medication adherence further create issues in patients with diabetes mellitus and CVD because of polypharmacy and the same. Based on the ROL, it was found that psychosocial aspects, socioeconomic class, and medication adherence were not properly researched and neglected in patients of Indian society. So, based on that, we measured the levels of distress related to CVD patients, impact of socioeconomic status and psychosocial determinants, additionally measuring the level of adherence and impact of polypharmacy on the distress. Methodology, it was a prospective observational study where we included patients of ACS, that is unstable angina, STEMI and non-STEMI. A total of 250 participants were seen. Amongst that, 105 participants included based on the inclusion criteria. After the study was duration from 5 months, October to 31st March, the study was conducted in Cardiac Center and Sri Krishna Hospital. Eligibility criteria, patients above 18 years of age, both genders, primary diagnosis of ACS and willing to consent. Exclusion criteria with a history of any major surgery less than a month or undergoing any surgery, lactating woman, psychiatric conditions, or unwilling to provide consent. These all factors were excluded based on the criteria that these factors could create additional distress or maybe the primary reason for distress in these patients. Patient screening was done when the patients came to OPD. Following that, the patients were informed about the study and consent was taken. Based on that case report form where data was collected, the CRF concluded of demographics, socioeconomic status was scaled based on Kupuswamy scale, CDI was done basis cardiac distress inventory, and adherence via adherence to chronic distress scale. Based on the interviews conducted in private settings, all the data were systematically documented and statistically analyzed. Results, majority of the population were over 61 to 70, while most of the male patients were patients of ACS. Following that, majority of the patients had minimum of one comorbidity followed by history of tobacco, smoking and alcohol. Surgical history was present in almost 80% of the patients, with most of the patients localized in urban settings. Type of ACS, most of the patients were of MI with sudden onset of conditions, and almost 68% followed polypharmacy because of their conditions of hypertension and diabetes. These were the 8 factors and additional 2 factors which we validated for our Indian population. These factors bear fear, uncertainty, disconnection, hopeless, changes to roles and relationships, overwhelm, depletion, cognitive challenges, and health system. Based on the distress score varied significantly among various factors. Highest was seen in F3, F4 and F1, which were changes to the roles and relationships, because diabetes and patients with hypertension were seen that patients could not come up to the normal role, and because of surgery and complications of diabetes they were advised to stay at home. Additionally, overwhelming depletion because of certain emotional burden on their condition and family, they were not able to do the normal job and feared poor prognosis of the patients. Additionally, these patients had poor economic impact on the condition because of polypharmacy, surgical burden. In spite of government policies and help from government of India, it was seen that patients suffered distress while taking medication from other populations. Polypharmacy, most of the participants reported high level of adherence, while polypharmacy with patients with low adherence compared to were not statistically significant, but it was observed that patients with diabetics were more not non-adherent to medications compared to patients with CVD. Additionally, distress, based on the overall findings, we found that distress varied majorly in diabetics compared to patients who were not diabetics, only had CVD related reasons. Distress in socioeconomic classes created a major burden on patients with CVD and diabetes both, as these created upper and lower middle class patients while taking medications and buying medications for same. Age group, it was found that people having age group of 61 to 70, that is older age geriatric population, had higher distress in patients compared to age group of 50 to 60 and less than 50. Distress varied significantly among female individuals because of higher hormones, and distress because of their roles and relationship changes which they felt like they were not able to do their work. Additionally, rural residents reported greater distress because of lack of access to healthcare, and comorbidity, polypharmacy, and adherence created significant impact on the distress related to these patients. Based on the findings, it was concluded that distress levels in CVD patients examine socioeconomic and influences, that it arises from financial struggles, emotional distress, and other factors which could relate to treatment related inadherence and changes, they especially belonging to lower economic strata and lacking social support because of lack of support from their individuals. Also, it was noted that patients impacted with adherence because of polypharmacy and related to complexity in financial burden because of treatment complexity, which because of ACS, diabetes, hypertension, and other comorbidities. Additionally, for sin, CDA and adherence was culturally evaluated. The limitations of the study which were observed, that results cannot be extrapolated to a broader population, as the outcomes of ACS were affected by socioeconomic positions, regional factors, and cultural behaviors to only settings of our location. Future directions, it is a longitudinal study to cohort track distress across various CVD stages. Early psychosocial interventions to help the counseling therapy and assign a psychologist for same. Disparity focused research to multicentric centers. Additionally, cost efficacy and policy integration and AI powered personalization for early detection of the same. Additionally, this was the ethics approval.
So your study focus on diabetes also in a patient of ACS.
Yes, sir.
You have mentioned in your methodology ACS, STEMI and STEMI and everything.
Yes, sir.
Myocardial infarction.
Yes, sir.
Actually, myocardial infarction itself is ACS.
Yes, sir. Sir, ACS actually has three classes: unstable angina, MI, and STEMI. These were the acute coronary syndrome.
You give us thrombolysis and STEMI.
Yes, sir.
You given? Yeah. It is a contraindication. In rural setup,
yes, sir,
probably psychological aspect is patient is not aware of.
Yes, sir.
This is more in urban area.
Yes, sir.
Depression, whatever anxiety, rural people may not aware of that. So we have seen your result.
Yes, sir.
And we have not seen any slide mentioning CKD. Diabetes patient die because of stroke, acute myocardial infarction, and chronic kidney disease.
Sir,
so despite this many patient, none of the patient had stroke and none of the patient has CKD.
Sir, if the patient has CKD or stroke, the primary diagnosis was supposed to be stroke and CKD, majorly than ACS. So
but
based
we have
on
not seen any data out of 100 or whatever number you have.
Yes, sir.
Not a single patient.
That patients were not enrolled actually, sir.
So they excluded.
They were excluded. As I mentioned, no primary.
And none of the patient ECG is shown.
Yes,
we
sir.
want to know what is the ECG picture. You have not done calcium scoring.
Yes, sir.
So certain things are missing. Anyway, as an intern, it is a beautiful presentation.
Thank you,
I compliment you. It's good, well.
You can include, like sir said, ECG, echo, and even lipid profiles. That could have been also be added in these all investigations. And for the stress, if you want to do on a larger study, stress is something a huge aspect of problem, not for a smaller group of problem. If you go to a rural area and if you just consider 250 people, their standard of living is very low as per their lower socio-economical status.
Yes, sir.
So their stress index can be low. They don't want to fly in the aircraft. They don't want to pay huge EMI bills,
Yes,
so if you want to do a study on a stress, you can choose a urban area, as sir said, and on a larger aspect of people. You will find IT people there, doctors will be there, the advocates will be there. All the professionals live in a tremendous stress nowadays, and this stress creates a lot of problem. Hormonal imbalance, the higher cortisol level, insulin resistance. They become a pre-diabetic, then diabetic, and all the complications can be seen. But good presentation as in fact.
Expectation of the rural people are very, very low.
Yes, sir.
They do not know what is anxiety.
Yes, sir. Sir, we were not, the questions were not the anxiety. These were the questions which was asked to them.
How illiterate or low literate people fill up your questionnaire?
No, sir, they were interviewed for same.
So
They,
it is a bias, isn't it? If you ask, તમને તાવ આવે છે નથી આવતો? If you ask a leading question, he is going to refuse. Questionnaire has to be given, patient can at least read and family member can read and give the answer.
sir,
If you ask question to the patient, there is some investigator bias that you have to nullify.
sir,
So we do double blind clinical trial.
yes, sir.
This is a single blind,
Yes, sir.
but it is open trial, I would say.
Yeah,
Not
no,
a
sir, it's an
single
open trial.
You also know the question and you know what questions answer you are expecting.
Yes, sir.
ठीक है, but as an intern we compliment.
Thank you, sir.
Wonderful.